So welcome to the joint session of SCCM, ESICM societies. My name is Jose Pascual. I'm the president-elect of the society. I have the pleasure to be co-moderating this session with Marlies, who's also the president-elect for the ESICM society. And we have a series of international presentations, Europe, US, Australia, and Japan, that we're really looking forward to hearing. I'll tell you that the Australian presentation is going to be a recording. The speaker could not make it in person, but we have the luxury of having Ranga, who's going to be answering questions from that group, but it won't be a live connection. So we're going to start a little bit different to your schedule. We're going to start with the European initiatives in grid and critical care by Dr. Jan de Waele. Dr. de Waele.
Thank you very much for the opportunity to discuss this important topic at this conference. My name is Jan de Waele. I'm an intensivist based in Ghent, Belgium, and president of the European Society of Intensive Care Medicine. We've been working within the European Society in the past few months on developing policies regarding to environmental sustainability, and this is what I would like to share with you today. These are my disclosures, none of them, in fact, relevant for this topic. This is essentially, and I won't go too deep into why we are doing this, but it's essentially what the problem is. And as you can see here, these are the temperatures, the average temperatures for every year. And in the past 20 years, there's been a rapid acceleration of the mean temperature on Earth. So this is the median temperature on Earth. And in fact, it was confirmed just a few weeks ago that indeed 2024 was the hottest year on Earth ever. And this, this comes back regularly, and we learned that in 2024, the November was the second warmest November ever recorded, and the warmest one was actually the year before. So it's really clear that we are confronted with an important problem. How does this translate? This is pictures from Valencia a few months ago, in which a lot of people died in huge floods that took on the city. The question, of course, is how is this relevant to our ICUs? And indeed, we see things. We like to elaborate on how climate change is affecting our care in the ICU and how we are confronted with the fluid shortages that we've seen and things like that. But it's important to understand that this is a two-way street. It's not only that climate change is impacting our work and the type of diseases that we're treating, but it's also important to understand that our activities also impact the environment. And this is essentially where in our policy document that we've been developing at the ESICM and that I will be focusing on most, actually this is what started it. It's important to understand that in Europe there may be slight differences. This comes from a survey that we've done among ESICM members, and you can see here at the bottom that yes, people are indeed, they feel that they are well informed, that they are concerned about it, and that they also feel that ICU professionals should take the responsibility there. But one thing that struck us in the survey is that they feel that they do not have enough knowledge when it comes to translating this into practice at the bedside. So this was the background to which our project was done. This is the result. This is available for free from the ESICM, the ICM website. It is a green paper which essentially establishes or reviews the policies or suggested policies to improve sustainability in intensive care. So these were our main objectives, not only give recommendations, but also document the impact of climate change on our ICUs and how actually ICUs and how this impacts ICU activities, but also to develop a framework for initiatives in intensive care. To this end, there was a task force that was created that met regularly, and the target was to develop a green paper to inform our members and stakeholders alike. Very important to understand is that we've identified different domains where we need to be active. Because in a lot of discussions, a lot of meetings, there's a lot of focus on what you can actually do at the bedside. And while this is, of course, very important and essential, it's also important to consider these different aspects as research, education, and scientific societies such as ESICM and SCCM itself as well. So let's first quickly go into the clinical care. Of course, this is the bedside work, and this is really very important. There's some important things to consider, and of course you work in a hospital, you're not isolated, and you need to be sure that you are aligned with hospital initiatives and identification of low-value practice. You know, a lot of things we do add very little benefit to our patients. It is important. Securing leadership support is very important in this. And I think it's very important to understand that being more sustainable is not always the same as making things harder, more expensive, or more difficult. So when it comes to the clinical care, we do acknowledge that there's a crucial role for ICU green teams. ICU green teams are multidisciplinary teams that actually are work bottom up. They are really strongly connected to clinical practice. And it's very important because they are able to identify the low-hanging fruit where a lot of things are being lost or a lot of resources are being misused. We do consider that there's different tiers. Some things are really easy and straightforward to do, require very little resources, but some other things indeed require more efforts, more investments, and it's important to understand that there are different levels of challenges involved. So clinical care, very essential, a key role for green teams, bottom-up initiatives. But it doesn't stop there, and I think this is one of the strong messages that we want to share, that also in other domains, such as research, we need to incorporate environmental sustainability in our educational efforts, but also we need to develop the tools to study the impact of the environmental impact of practices, things we do on a daily basis. And it's important to speak the same language and use the same tools, so developing things like a core outcome set for environmental sustainability, I think is highly needed, so we can really compare different things, and also developing a research agenda, prioritizing key interventions is important. So research, yes, but also education. We recommended a number of things in the green paper, focusing on not only developing educational courses, such as we do in our annual conference. There's a course on environmental sustainability, but also making sure that sustainability is embedded in all the things we do. When we develop guidelines, and not guidelines on sustainability, but for instance, guidelines on hemodynamic management, sustainability should be one of the things that are considered. And this is the case for courses, for guidelines alike. So making sure that the concept, the topic, really is considered in all these different initiatives. And finally, ESICM itself, as a scientific society, the way we operate, the way we organize our conferences, also there we need to take responsibility and partner, for instance, with venues that are easily reachable, with public transportation, that have certain labels, et cetera, et cetera. So it's also about ourselves and the way we organize things that should be considered. So in conclusion, I know it was a brief summary, and I would really recommend you to have a look at the green paper where all of this is more detailed. The document is available for free. And again, while clinical care is very important and one of the key elements, I think it's a responsibility of scientific societies to also take it to the next level and involve research and education. It's a joint responsibility, and also this is very important. This is not a project of one or two individuals in a team. It's the whole team's responsibility, and it's not something that you outsource. ICU professionals, of course, playing an important role, but also ESICM does intend to lead by example, and we want to make this a long-term project for our society. So my invitation is to you to join this green movement of being intensively green. Thank you very much.
Thank you very much, Jan, for a great overview, but also I'd like to take the opportunity to thank you for leading the ESICM in this great effort, and it was you who alerted us to the rising dangers of climate change and the absolute urgency to focus on sustainability. So thank you. It's now my great honor and pleasure to invite Professor Dr. Atagi from NARA in Japan, who is going to tell us, inform us about the situation in Japan. And this will be very exciting because all of us are trying to do the same. It's important worldwide, but we're all learning from each other and we're having different experiences. So it will be great to hear what happens in Japan. Thank you, Dr. Atagi.
Thank you for inviting this session. Hello, everyone. Today, I'm from Nara, near Kyoto, Japan. My name is Kazaki Atagi. Today, I would like to talk about sustainability initiative in the ICU, focusing the current situation in Japan and future prospects. But in Japan, there is a little awareness about green ICU. Then my presentation may be a little bit wrong, sorry. Firstly, COI disclosure, I have no financial relationship to disclose. The intensive care medicine continued advanced in ICU are becoming more specialized and technology sophisticated. However, medical resources are limited and issues such as workforce shortage in ICU bed capacity constraints must be addressed to ensure the sustainability of ICU care. To build sustainable ICU system, we need to consider various factors, including human resource, medical cost, technology innovation, and the aging population. In Japan, we might not have even reached the starting line for this action, green ICU. However, the result, we are involved in this action. In Japan situation, the OECD data, according to OECD data, the number of ICU beds per 100,000 people in Japan, 5.2, significantly lower than in US and England and Australia. 2024, Japanese government is implementing the policy to change the way Japanese people works, including the physician. Legal business hour should be 40 hours per week. Maximum overtime hours should be less than 1,860 hours per year. While reform the crucial maintains healthcare quality, we must carefully assess how it is impacting the ICU workforce and quality of critical care service. Due to restriction of working hours, the already limited number of intensivists in the even more difficult to secure sufficient staffing. As a result, from 2024, many ICU in Japan moving toward converting to low-intensity ICUs. From another perspective, the number of ICU beds per hospital in Japan, mostly 20 or less. There is a few physicians. The result of ICU dispersed, and when we consider the impact working in our regulation, it is moving toward centralization of ICU. And another situation in Japan, many aged country in all over the world. 2022 September, Japanese government released this slide shows over 70 ages, 50%, over 65 is about 30% of population. Then in emergency ICU hospital mortality timing of death, hospitalization, patient over 75 years found early half of them died hospital, about 80% of they died within 2 days of admission. This data shows how many patients receives invasive treatment in the invasive intensive care until the very last minutes before they die. Next slide is advanced directive, about advanced directive. Where the difference end of life care in the emergency and intensive care setting in Japan and the US. This shows percentage of the public owing advanced directive in Japan. Only 5% population process so-called advanced directive. I began to wonder might be something to do with the reason why people receiving resuscitative treatment until very end of their lives. Then consider the current situation in Japan. The first step is consolidate ICU bed and physician from hardware perspective. Furthermore, it is essential standardized treatment and disseminate education according. While linking these of next generation, it is necessary to standardize treatment using new tele-ICU, another method. After that, I think the sustainable ICU will begin by eliminating good wasting in ICU and effectively utilize medical resource through ACP. One key initiative from ICU sustainability healthcare professional education. The notable example FCCS program developed by SCCM in 1994. FCCS designed, trained non-intensivist physician and nurse, other healthcare profession to early detection of sign of deterioration, performed appropriate evaluation, and consult intensivist and timely manner, and ethics. In Japan, participation in FCCS course has become increased, contribute to standardized critical care in expansion and intensive workforce. This slide shows young physician and other professionals also attendance. The implementation FCCS in Japan led to significant advancement, including established extensive critical care network and increased number of critical care physicians and standardization treatment practice and critical care. Another promising solution for the sustainable introduction tele-ICU systems as proposed by Japanese Society of Critical Care Medicine. Tele-ICU allows specialists to provide remote support, enabling high-quality ICU management even in regions with a shortage in intensivists. As Japan first faced physician work restriction and regional disparities in healthcare. The implementation tele-ICU will be essential maintaining and improving ICU service. Last slide, near future. Today I discussed the current situation of challenge of ICU sustainability in Japan, as well as potential future direction. Japan faced a shortage ICU bed intensivists, making essential development sustainable ICU care system. The aging population growth, advanced care planning, and end-of-life discussed must be a priority. Education programs like FCCS play a crucial role in improvement ICU care and workforce training. The implementation of the tele-ICU be key maintains ICU quality while addressing task force constraints. Finally, Japan is standing and maybe first step sustainable ICU care. I hope we work together develop better, more sustainable ICU system. Thank you for your attention.
Thank you very much, Professor Atagi, for giving us an overview of the situation in Japan. And we now move on from Japan to Australia. As you've already heard, there will be a recording on this occasion, and we have a recording by Professor Forbes McGain, who again is a leading expert in this area, has written a lot about this topic, and is a great resource for advice and directions. So we look forward to Professor McGain's talk. Thank you.
At Western Health and at the University of Melbourne. Being sustainable in the intensive care unit, a real opportunity. Disclosures, McMonty hood and a reusable N95 mask, as well as acknowledgements to Western Health, University of Melbourne, the College of Intensive Care Medicine, the Australian New Zealand Intensive Care Society. There are 3 articles I just want to take home to read if possible at some point, to learn a little bit more about what our carbon footprint is in the ICU and what matters and what are the hotspots. This was one we did for 10 patients at Melbourne, Australia, and 10 in United States, St. Louis, Missouri, where we looked at the carbon footprint of treating people with septic shock and looking at hotspots there. The second article I want you to be aware of is the environmental footprint of regular and intensive care inpatients in a large US hospital in New York. This was by Prasad et al. Interesting study looking at comparison between inpatients in intensive care versus those who are on general wards, and having about double the carbon footprint as you might expect in intensive care. The third one is what we call a material flow analysis, which is much more about flow of stuff, of things, and working out what the footprints are associated with that. So it's not so much energy. This is an interesting Dutch study done by Nicole Heldenfeld and her team. Hats off to them. Really interesting work, worth looking at. One that we did then was looking more nuanced, just looking at carbon footprint of pathology testing. This was with Scott McAllister, who's an LCA life cycle assessment expert with me, done some interesting work also in other fields, but very much finding, for example, that one FBE, full blood examination, will be equivalent to driving your average American car half a kilometre. Now, that's not very far, under a third of a mile, but it's just the sheer volume of these things being done, as well as the cost of them, and potentially low value in some cases. That's important. And what about radiology? The carbon footprint of hospital diagnostic imaging in Australia. You can see that MRIs and CT scans dominate. X-rays and ultrasounds are rather minor, and that one MRI scan is equivalent to burning about 2 gallons or a bit over 8 litres of petrol per MRI scan, with about half of that from CT scans, so also being quite important for CT scans because they can be done rather rapidly. And we also see carbon footprinting occurring in medication areas. Here is the environmental footprint of paracetamol or acetaminophen, led by Jess Davies International Group. You can see that on the top there that a tablet will have 1/50th to 1/100th of the carbon footprint of a glass vial intravenous preparation of acetaminophen. Read more about it. It's all there in the British Journal of Anaesthesia. And we see here reusable linens from Western Health Melbourne Intensive Care Unit. On the left-hand side, you can see the reusable PPE gown in green, the reusable surgical gown in purple in the background there for central line insertion. You can see also the reusable linens, drapes and blueies and pads that are being used for patient care. I also want to mention, I know this will come up with Deepak's work, the role of sustainability quality improvement led by Lou Trent from New Zealand, Australian New Zealand Intensive Care Society, Beginner's Guide to Sustainability, well worth having a look at. You can see that online anywhere in the world. And I'd like to finish up by stating that the broader topic of sustainability in healthcare, whether it be in research here on, you can see why is it carbon neutral, or the sustainability in policy development in hospitals, the Australian Commission on Safety and Quality in Healthcare, the equivalent of your joint commission, all of this can be engaged with by intensive care physicians to make broader change. I'd like to then introduce Dr. Deepak Bhonagiri, who's going to speak very soon about the broader challenges and opportunities of sustainability in healthcare in the ICU.
Deepak Bhonagiri is my name. Forbes let you know about some individual projects. Now I'll let you know about some of the progress and challenges in the environmental sustainability space in Australia and New Zealand. I think the key achievement that I would like to highlight here is people are talking about environmental sustainability and carbon footprints in our ICUs, on the ward rounds, in hospital journal clubs, and also we've got sessions in our annual scientific meetings where we talk about this. There's more research being done, as you saw from what Forbes spoke about. And also, as Forbes spoke to you, we wrote these two documents, the Beginner's Guide to Sustainability and the Green Teams document. So a fair bit of work going on there, and we hope to keep that continuing. Coming next to some of the specific programs, the pathology and radiology stewardship programs. There are many that we're doing, and we're trying to bring them all together so we can get some statewide or national guidelines. We did some carbon footprinting of our hospitals as a baseline, and once we put a lot of these measures and projects in place, we'll be able to regularly measure our carbon footprint and work out what the impact of these projects and the entire carbon footprint of our ICUs is. In New South Wales, I'm very happy to report we could set up an ICU Net Zero Hub. We've got 2 funded staff to help us set green teams in each of our 39 ICUs, spread projects across the 39 ICUs, monitor and measure the progress that we make in terms of the carbon impacts, and use this as a template to spread the environmental sustainability message and projects across our system. The challenges, as you know, are many. We've got the politics, leadership, and engagement, which is always important. We need a top-down approach. We need those carbon targets to be set so that our health executives are forced to support us in some of the research and the projects that we do. Changing procurement contracts, changing workplace culture, those are other things we need to look at. We need to be able to engage with industry to reduce the carbon footprint of some of the consumables that we use in our ICUs. And finally, my vision is that we move away from recycling as being the only thing we do in environmental sustainability, and we focus first on reduce and refuse. We refuse admissions to ICU if they're inappropriate. We reduce the tests if they're not required, and that would impact carbon footprints a lot more than just recycling will. We need to create global networks, and forums such as these are very important for like-minded people to come together and talk about their projects and to be able to socialize projects that are being done. So thank you for the opportunity to speak. My email address is there for those who want to get in contact with me. Enjoy the rest of the conference, and thank you again.